MS relapses are very often occurring at the time when the patient presents with new symptoms. It is important if we entertain an MS relapse to ensure that the patient doesn't have a pseudo-relapse, meaning a worsening of neurologic function in the context of an other illness, such as an infection. But once we arrive at the point that the patient has a relapse, we normally entertain a short course of steroids. In recalcitrant patients, we also have other interventions, such as plasma exchange or ACTH that can be considered in the patients depending on local availability. The goal of steroid treatment is to interrupt the worsening process. Whether or not steroid treatment leads to a long-term beneficial outcourse is a matter for question, but in general we can reduce the nadir or the worst presentation of the patient and hopefully in the short term return the patient to earlier functioning. How long should we treat with corticosteroids in the context of a relapse? Should we consider a taper or not? In general, and this is something where all of us have slightly different approaches in the field, I, in my practice, use a 3-day, 1 gram of methylprednisolone per day approach. I do also use an alternate approach, and this is particularly important for patients that don't have home infusion or other benefits. I use 650 milligrams of prednisone 2 times a day for 3 days. This is normally well tolerated. The 1.3 grams of prednisone per day equates to 1 gram of methylprednisolone in its dose equivalency. Obviously, this would need to be done in a patient where one is aware that they tolerate steroids, because as always with steroids, there is an ultimate risk for psychosis associated with treatment, particularly in patients where we never had an experience of how they react with steroids. A lot of patients, when faced with the diagnosis of multiple sclerosis, inquire about alternate treatments, non-standard treatments. One of the treatments that is considered or very often on the forefront of patients is bone marrow transplant, for example. This is a treatment that certainly may have its benefits. At this point in time, the long-term negative consequences are less well understood than with other therapies. So in a patient with highly aggressive multiple sclerosis, this is certainly something that could be considered in an experimental setting in the hands of an appropriate transplant center. A few years ago, there was a consideration of whether or not veins to the brain had any contribution to the pathology of multiple sclerosis, and at that point in time, venous dilation, the whole concept of CCSVI was being discussed. It was brought forward significantly by an Italian research group. Over the years, both research of the National Multiple Sclerosis Society and also research sponsored by the Canadian Multiple Sclerosis Society have significantly discredited this theory, and at this point in time, such approaches should not be used by MS patients. I think there is enough evidence to not use these approaches. Generally, regarding alternative and complementary therapy with supplements, it's important to keep in mind that some supplements may actually be immune stimulating, and with that may not necessarily be indicated in a disease state like multiple sclerosis, where the immune system is not underactive, but actually already overactive. Whenever one considers such alternative approaches, I think it's important to not set aside the proven therapies, the proven benefits of medications that have undergone phase 3 trials and have been studied and have held muster during the regulatory review.